Good afternoon, everyone. My name is Evelyn Blank, and I'm the director of the New York City Training and Technical Assistance Center, and I am very pleased to welcome everybody to today's seminar, webinar with clinical work with young children in foster care. I'm joined here by Dr. Susan Chinitz, who I'll introduce shortly. Before we get started, I just wanted to talk about a few logistics about the webinar today. And as we've always done in the past, this webinar is being recorded, and it will be posted along with the slides on the TTAC website. We'll also be taking questions throughout the webinar and have time at the end set aside to answer these questions. So as such, we ask that you put your questions using the chat box functionality. So I want to welcome everybody, let you know who we are. New York Center for Child Development has been a major provider of early childhood mental health services through both federal, state, city, and philanthropically funded programs in New York. We also have a long history of providing system-level expertise to inform policy and support the field of early childhood mental health, which we do through training and direct practice. New York Center for Child Development was selected by the New York City Department of Health and Mental Hygiene under Thrive New York City to develop a citywide early childhood mental health training and technical assistance center, TTAC. NYCD's subcontractor in the TTAC is the New York University McSilver Institute for Poverty Policy and Research, which offers clinic, business, and system transformation support statewide to all behavioral health providers. And I just want to say that this has been an extraordinarily exciting partnership in really combining clinical expertise along with business sustainability principles and real infrastructure. So we've been very excited about the work. I'd like to direct people to our website where you can see upcoming trainings and also other archived webinars. If you'd like to join our mailing list, also go on there and please indicate that you'd like to be added to the mailing list. So it is now my pleasure to introduce Dr. Susan Chinitz, who is a psychologist who specializes in the areas of infant mental health and developmental disabilities in infancy and early childhood. She is also the clinical co-director of TTAC. She is the former director of the Early Childhood Center, the Center for Babies, Toddlers, and Families, and the Parent Infant Family Court Project, all therapeutic programs for children birth to 5 years of age at the Albert Einstein College of Medicine. Dr. Chinitz is currently affiliated with the Center for Court Innovation, where she is spearheading the Strong Starts Court Initiative, an effort to integrate developmental science into family court practice for infants and toddlers. So thank you, Susan, and we look forward to a very interesting webinar.
Okay, thank you, everyone, and thank you all for joining to think together about young children in foster care. Today we're going to focus on children birth to 5 years of age. And before we start, I just want to acknowledge that this work is very evocative for clinicians. Many feelings are triggered as we learn of the neglect and traumatic histories the children endure, and as we share with them their often too long road to permanency. I'm hoping if time permits that you'll have the opportunity during this webinar to share some of your thoughts and reactions to this work, and that way we may be a source of support to one another. If time does not permit, I'm happy to try to be available to any of you outside of the context of this webinar. I'm sorry. Okay. I'm sorry, we're just having, okay. Today we're going to cover the following topics. I'll talk about characteristics of young children in foster care, characteristics of their caregivers, and of the child welfare system as a context for this work. We'll spend a lot of time talking about the complex clinical issues that are posed for the therapist. We'll talk about when and how children's therapists can make a difference for children, parents, and foster parents. I'll talk about the evidence-based therapeutic approaches for young children in foster care, and I'll share some therapeutic resources that can be used in the course of a child's psychotherapy. To begin with, children under 6 make up a disproportionate percentage of children in foster care. They constitute about 47% of foster care entries. And despite the large reductions in foster care over the last several years, the population of children birth to 5 has not experienced a similar decline. Infants and toddlers in particular are the largest cohort of children who enter foster care. That's true both nationally and locally. and they have a rockier course in foster care than older children do. Infants stay in foster care longer than older children, and they are more vulnerable to repeat maltreatment, whether they are in foster care or home with their families. 20 to 25% of infants who are reunited with their parents return to foster care, and multiple moves in foster care are quite typical. As we know, the years from birth to 5 are a critical period for the development of attachment, language and cognitive development, self-regulation, social competencies, and school readiness. And we know from developmental neuroscience that exposure to traumatic events and disruptions of primary attachments have their most deleterious impact in these earliest years. The children have multiple levels of risk and adversity. Many have prenatal exposures to drugs and alcohol. In fact, that's a very common reason for removal and placement in foster care at the outset. There are high rates of prematurity and low birth weight. The vast majority of children who are in foster care come from poverty-affected families, and as I know you know, poverty is the single biggest risk factor in early child development, and it is the umbrella under which many other specific risks occur, housing insecurity and homelessness being an important example and a very common characteristic of the families of young children in foster care. The children have had multiple caregivers and or multiple changes in caregivers, both prior to entering foster care very often and then certainly once they enter foster care. They have unmet needs in the area of safety, shelter, medical care, hunger, physical and emotional comfort, and they've often experienced a somewhat chaotic lifestyle with no routines that support regulation. And then, of course, there is the neglect or the traumatic experiences that result in their removal, physical or sexual abuse, exposure to violence, and other forms of trauma. Our children have often witnessed adult criminal activities and arrests, adult substance abuse, and adult sexual activity as common examples. This is a list of the many reasons or opportunities that occur where children experience repeated attachment disruptions. One is parental incapacitation, either due to mental health or substance abuse treatment. Parents have psychiatric hospitalizations or inpatient treatments for substance use disorders. We are all learning about increasing numbers of deaths related to drug overdoses. A significant percentage of the parents have had some period of incarceration. Sometimes parents abandon their children in their cases because there are just too many unsurmountable problems. And then, of course, there's the removal from parents that foster care inherently conducts, and the multiple moves of children once they're in foster care. And then even reunification with parents down the road usually involves attachment disruptions as children leave the foster homes in which they've developed intimate relationships and a sense of security. So when we think about the definition of toxic stress, the strong, frequent, or prolonged activation of the body's stress response system in the absence of adult support, we can agree that young children in foster care meet these criteria. Using a different framework, in a national study of children in foster care, it was found that 38% of children had experienced 4 or more adverse childhood experiences by the time they were 2 years old. And I believe this audience knows that the 4 or more is the threshold at which there's a marked increase across so many different types of difficult outcomes. In a more recent study, the 0 to 3 Safe Babies core team evaluation showed that 59% of the children served in the Safe Babies core teams had 4 or more ACEs by the time they were 3 years of age. And their parents have very many complex needs of their own. Many of the parents of children in foster care were in foster care as children themselves. They've had a high number of adverse childhood experiences. They often have few, if any, social supports. They struggle with long-term mental health problems, substance use disorders. They've often been victims of violence or have had violence exposure both in their childhoods and often in their adulthoods as well. Some have cognitive limitations or learning difficulties. There's often a low level of educational achievement. Some are involved in the criminal justice system as well as the family courts, and there's a high level often of conflict and stress in their families. And the context for this clinical work is the child welfare system, which imparts many additional problems. There are multiple professionals and limited communication between them, frequent turnover of casework staff and of attorneys. There tends to be a punitive or critical stance toward parents. Foster parents have very little preparation about a child's specific history or about psychoeducation about trauma overall. They don't get that much guidance on positive behavior management for children with trauma and attachment disruptions. Very often foster homes are crowded. Sometimes foster parents are taking care of multiple children and are also working, very dependent on child care, which can be of questionable quality. We've talked about the multiple moves that children make in foster care due to sibling reunification, child behavior problems, emerging relatives. There are a lot of reasons why children get moved. There are often poor visit practices. We'll talk more about that. There's sometimes confusion about confidentiality and who can share what information with whom. There's confusion or problems about consent and decision-making when it comes time to get children in services. And there's a loss of service every time a child moves in care. And there are long delays in court process and permanency planning. Most important to us as early childhood clinicians, there's enormously limited expertise in the child welfare system in infant mental health and early child development, including critical areas such as attachment theory and research and developmental neuroscience. And so it's not surprising that there's a history of poor outcomes. Children in foster care have high rates of medical, developmental, and emotional and behavioral problems. They experience frequent placement breakdowns. There's a long period of instability. They have poor access to, or at least not timely access to, corrective or therapeutic services, and very few have access to high-quality early childhood education programs. Poor outcomes for parents usually involve high levels of conflict with child welfare staff, high levels of conflict with children's foster parents, missed visits with children, poor compliance with services, and high levels of recidivism of their mental health and substance abuse problems, often leading to maltreatment recurrence. The behaviors of children in foster care certainly, of course, vary from child to child, but there are certain behaviors that we see quite commonly among them. Dysregulation being the most commonly reported behavior, dysregulation in sleeping, and frequent and easily provoked tantrums being the most common examples. Children have high levels of anxiety often and show a lot of negative mood, irritability, depression, flat or constricted affect. These are children among whom you don't see the normal exuberance of early childhood. Many of the children struggle with overactivity and impulsivity. Aggression is quite high in this population. Many of the children show sexual behaviors. There's a subset of children who have eating disorders, specifically hyperphagia, which is an eating disorder that involves overeating and sometimes food hoarding. They show indiscriminate social behaviors reflecting their attachment disorders. Many have fears, fears that sometimes give us cues to things that might have happened to them, fears of diaper changes, fears of bathtubs, men, of being alone. They show limited play or exploration at times, and in the more serious cases, we see children with self-injurious behaviors and developmental regression. Very often, young children in foster care meet the criteria for complex trauma, which describes the dual problem of children's exposure to frequent and prolonged traumatic events, as well as the impact of this on both their short-term and long-term outcomes. In the context of all of these issues, typical child welfare interventions make use of programs like parenting classes and anger management, which are untested interventions with no evidence of their efficacy. There tend to be few or no interventions that address the specific parenting problems that resulted in maltreatment or that target parent-infant interactional difficulties. There are very few trauma-focused interventions, and especially an insufficient focus on parent-infant relational repair. Everything we've talked about so far contributes to the complexity of this clinical work. The children have complicated clinical presentations and comorbidities. In addition, there are multiple parents and caregivers, and thereby there are multiple perspectives to hold in the therapeutic work. There are also multiple systems involved. In addition, there's also the therapeutic dilemma posed by prolonged court processes which impede the development of attachment between a child and a parent, a critical foundation for successful reunification, or the prolonged court process contributes to attachment disruption by working toward reunification when a child has already consolidated attachment with an alternate caregiver. Sometimes we don't know what we're rooting for when we're working therapeutically with children who have been in the system for a very long time. So taking these one at a time, these clinical complexities, we'll start with the fact that the children have multiple symptoms and often multiple clinical disorders. Using the DC 0 to 5 as a framework, the children qualify for developmental problems, post-traumatic stress disorder, often complicated grief disorder of infancy and early childhood, again, often eating disorders as well, and in the more severe cases, reactive attachment disorder or disinhibited social engagement disorder. And as I've said before, there are often comorbidities where children have more than one of these disorders at the same time. Second, in our discussion of therapeutic complexities are multiple caregivers who are involved with every child. There can be one or two parents. The parents can both be respondent parents, meaning they both have allegations against them, or there can be one respondent parent and one non-respondent parent. And then there are foster parents who may be kinship foster parents or who may be non-related. They may get along or may not get along with the parents. And then there are other members of the extended family who may come forth immediately or may come forth later, who may want visits with the child, who support or don't support parents' efforts to reunify with the child, or who may have a history themselves of prior involvement with the child welfare system. At this point in time, the system leans toward family as a preferred resource for children. And then the child welfare system adds many, many other people. Every child has an attorney. In New York City, most children are represented by an attorney from the Legal Aid Society. Each parent has an attorney. ACS joins the case with an attorney. There's a foster agency caseworker, an ACS caseworker, and a family court judge. And the kids are involved in multiple systems, sometimes like other children and sometimes beyond typical for other children. So kids have a pediatrician, they may have an early intervention provider, there may be child care or providers or preschool teachers. Many parents are working with the power of two now, and they have a power of two coach. Sometimes the child has a therapist or there's a dyadic therapist, and then there are the parents, individual therapists, substance use disorder counselors, and other people. It's a big team to keep together. So we'll talk about the multiple perspectives that therapists have to hold in this work. We'll start with the parents' experience. Parents are often quite angry at the system for removing their child from their homes and from their care. Almost always there's enormous sadness and grief. Parents feel shamed, they feel judged, they feel like it's not safe to ask for help. And at particular times of stress in their cases, we see lots of dysregulation of parental affect and behavior. They're often overwhelmed by service requirements. They're often in conflict with a foster parent, and they're often quite confused. This is a very complex system, and parents don't always understand the status of their case, what's expected of them, what the timeline is, or things like that. When we consider the perspective of foster parents, we start with the fact that they're often overextended. They often have many children in their care, including foster children and sometimes their own children. As I mentioned before, they're often working as well. They lack information. They take children in their homes with very little information about the children's histories. And there's an inherent conflict in their role. They're asked to become attached to a child, though the child may not stay in relation to them. And they're asked to be extremely responsible, although they're not authorized to make any decisions for the child. A foster parent may be fearful of a parent, may be angry at a parent, and for kinship foster providers, they often have a history with the parent. For all foster parents, there is uncertainty or unpredictability about the outcome for the child in the context of the foster home. When we think about the therapeutic alliance that we form with the child and a caregiver, that often depends on how the case comes to our clinical attention. If a foster parent initiates the referral or if a foster agency initiates the referral, we're often working with the foster parent and have little access to the birth parent. Sometimes when we don't have access to the birth parent, we tend to collude with foster parents or foster agencies in their sense of needing to protect the child from the parent, or in the sense of the parent being a danger to the child. The foster parent may agree with a referral for mental health services or may disagree. And even if they agree that the child needs therapy, the foster parent doesn't always see herself as relevant to the child's problem. So she may make herself available to the therapeutic work, or she may delegate and drop the child off, or have other people in the family bring the child. So we don't always have the access that we need to the foster parent. I'll argue that that is a situation that we should not accept as is. I guess most important to all of us is to consider the child's experience, and here there are many things to think about. These are little children. They're infants, toddlers, preschool age. They're facing lots of different adversities and separations. They have intense fear and intense sense of helplessness. Their fearfulness may be obvious, or it may not be obvious. They have a profound sense of loss. These are children who lose familiar people in their lives. They lose their extended families. They lose what's familiar to them, their routines. They have often very unacknowledged grief. Maybe because they're so little, people don't appreciate how much loss and grief the children experience. They're disoriented often, getting used to new people, new homes, new sounds, new foods. Again, adrift from everything that anchored them before. We see a lot of sadness in the children. They have conflicted loyalties. Sometimes they're afraid to show their burgeoning attachment to foster families, feeling like that would be very upsetting to their parent. They're often asked to carry secrets and not tell people important things about their lives and histories. They often feel very rejected and unworthy of love. Helplessness is a very common feeling. When I think about young children in foster care, I often think about Bowlby's very important article on knowing what you're not supposed to know and feeling what you're not supposed to feel. Because children in foster care often know a lot more than people think they know, but are not allowed to acknowledge that. And certainly they have feelings that go unacknowledged as well. I think that's an important concept to keep in mind and that we have to be very attuned to. There are many points of stress for very young children during the course of their case. There is the stress of long periods of neglect prior to being placed in foster care and sometimes even after they're placed in foster care. Then, of course, there's the event that resulted in the removal. The removal from the parent is probably the most acute point of stress for the child. Some children have stays in the children's center prior to a foster home being identified, and we're learning about the length of time that many young children spend at the children's center. Visits with parents are a point of stress for children. We'll talk more about that. Transitions between caregivers and foster homes is an enormous and unrecognized and underaddressed point of stress for very young children. As is parent and foster parent conflict, not too much attention is paid to this, but this is a very painful experience for young children. It's like being in the middle of a very contentious and conflictual divorce. Children often see conflict and arguing, if not overt fighting, between parents and foster parents. There are many moves in care we've discussed, loss of not only foster parents, but loss of other people in the home that the children have become attached to, loss of grandparents of the foster home, the other children who live there. Okay. And just a word about visits for a few minutes. Visits, meaning contact time between parents and children in foster care, are very necessary and very important. They're highly correlated with the rate of reunification. However, they're also often quite stressful for both the child and for the parent. Visits are highly triggering for parents and children. Parents and children can see each other as trauma triggers and remembering things that happened before. And there is the constant reenactment of separation at the end of every visit. We often see very severe dysregulation in children after visits, and often there's a request that visits be stopped because of how children behave afterwards. I'll also mention that visits often occur in small and crowded spaces with insufficient toys and materials, and that there's usually no opportunity for parents to provide the kind of caregiving that really is more typical of a parent-child relationship. No opportunity for parents to feed, bathe, put children to sleep, or do the things that parents usually do with the children. Issues for therapists. We usually have very limited and incomplete information on the child's history. And the child has limited information. The child may or may not have ever lived with a parent. They may not know that a foster parent is not their parent. They may not know why they're not living with the parent or where their parent is. They often don't know or are not told why they're moving from one home to another. Again, I think because the children are young or because there are so many other competing needs in the system, there's very little explanation given to children about all of these very profound issues in their lives. And then as therapists, is it okay to discuss these things with a child? I often use the example of a little boy I worked with whose mother was incarcerated, and she felt very strongly she didn't want her son to know that she was incarcerated, but it left with no other explanation about where she was. And as a therapist, it was hard to know what to do about that. She didn't want anybody to reveal that to her. The child does likely know more than other people think they know. When I finally asked this little boy if he had to guess where he thought his mother was, he said in jail. But these are all the inconsistencies that we're handed with all the time. And as therapists, we also get concerned that the child's emotional safety is not considered. Sometimes a caseworker transports a child to appointments so that they're not with somebody that they have an attachment to. Sometimes parents exchange the child at a police precinct, which gives all kinds of messages to the child about their safety. The system is not always focused on the child's emotional safety and support. Personal issues for us as clinicians is sadness. It's very hard not to become very sad for the children and their experiences. We also become angry at the system for the things that get imposed on children. We feel frustrated by our inability to make significant changes for the kids, and the issue of vicarious trauma certainly comes up in this work. So where can we make a big difference? There are many places that we can. This is a long list, but I'm going to go into them a little at a time. First of all, therapeutic work with children. Most importantly, we need to attune to the children's cues and miscues, and we need to resonate to their feelings and experiences. We have to try to make the children feel understood. Very often, no adult, parent, foster parent, caseworker has really worked to make a child feel understood and validated in their feelings. We need to help children with narratives of all kinds. We need to help them with trauma narratives. We need to help them with narratives about their separations. We need to help them with explanations in general. The fact that they may have two families or two mommies. What does adoption mean? What's an agency, a court, or a judge? They hear a lot about this, but nobody explains to them. I would say these last things we discussed are the most important parts of clinical work with children, to acknowledge their experiences, to acknowledge their feelings, to even translate the cues that they give in a miscued kind of way. So the children who are aggressive, as an example, are often quite frightened underneath the aggression. In addition to all of that, we need to do developmental monitoring. These children have very high rates of developmental language and learning problems. They're often under-detected and certainly under-intervened with. And it's helpful if we can provide preschool consultation or consultation to whoever's taking care of the child out of the home, because sometimes their behaviors can be challenging in those settings as well. In our work with foster parents, I would say that psychoeducation about the impact of neglect, trauma, and attachment disruptions on very young children is one of the most important contributions we can make. Foster parents are not given this background when children are placed in their foster care. And their behaviors are challenging, and when they understand the challenging behaviors through this lens, foster parents can sometimes, very often in fact, become more empathic to the child's situation. It helps if we're responsive to their expressed needs, because there are many. It helps if we can provide guidance on behavior management in the context of trauma and loss. I don't know how many times I heard a parent in a waiting room say to a child who was acting up, "I'm going to bring you back to the agency." That happens over and over again. We need to help foster parents understand the importance of touch and comfort, the needs of young children to have nurturing care, to be held, to be rocked, to be sung to have the same needs for nurturance that other children have, if not even more. We also need to acknowledge and address the conflicts in the foster parents' roles, as we mentioned before. And we need to assist them with referrals and in dealing with complex systems. They've got a lot on their plates, and it's very hard for them to deal with the complexities of referrals to EI, to CPSE, to the other services that they're trying to get to children. It's also important to acknowledge to foster parents the enormous difficulty of the job that they've taken on. Not everybody gives them that recognition. In our therapeutic approach to parents, I think a trauma-informed approach is the most important frame. 2/3 of parents of young children in foster care have also experienced 4 or more ACEs. Whether we know that they've had a traumatic past or not, it's a safe assumption, and it goes a long way to work under that assumption. We know that trauma negatively affects the parts of the brain involved in planning, evaluating situations, thoughtful decision-making, and problem-solving. And so we need to see the parents' compliance with services, punctuality in services, confusion about appointments through that lens, and not automatically think non-compliance in every one of those circumstances. When we think about parents as having a trauma response, we know that coming to the foster agency for visits, coming to court, may remind parents of the trauma of their child's removal or of their own childhood histories in foster care, and that there's a lot of psychological avoidance of these interactions. Some parents have more of a fight or flight response. They're overreactive to stressors. They're focused on the threats around them in terms of the child welfare system, and they show a lot of behavioral dysregulation or agitation. Again, understanding these as traumatic responses and not as signs of a parent having severe mental health problems or being a danger to the child is very important. Parents often have mistrust of relationships and of authority figures. They have strong feelings of helplessness and hopelessness. And often substance use disorders have to be understood in the context of strategies for coping with these very intolerable feelings. We often see relapses in substance use treatment and substance use disorders when parents have stressors in their child welfare cases or setbacks. It's helpful in working therapeutically with parents to have a therapeutic stance of positive regard, to look for both their personal strengths and their parenting strengths and to underscore those. Again, to explain things to them repeatedly as needed. They don't always process information the first time they hear it, especially in the context of very heated proceedings. Consistent with the CPP model, it's helpful to try to help them solve their problems of daily living. A lot of psychoeducation about their own trauma responses helps them understand their behavior and their impact on other people. And very importantly, psychoeducation regarding their children's attachments. It's very common to hear parents think that their young children who are not living with them should be very attached to them just because they are the child's biological parents. Often parents get very upset hearing young children call a foster parent mommy or needing a foster parent to be in a visit with them because of their fear or wariness around a parent that they don't live with. Again, we can go a long way in helping parents understand that children are not looking to reject them, but this is how children's attachments develop. It's helpful to acknowledge the pain of repeated separations, to ask parents if they want some supports in their visits, and also to teach parents ways of interacting with their young children. Very often these are skills that we acquire intuitively, being a parented child ourselves, and many of our parents of children in foster care have not had those experiences and don't know the kinds of things that we do to play with, engage, and have fun with young children. Other somewhat lofty but extremely important therapeutic goals to hold on to. One is to support the relationship between parents and foster parents to the extent possible, to do what we can to buffer the conflict, to explain each other's perspectives to one another, or even to get them together for some co-parenting meetings. Second, to advocate for developmentally appropriate transitions for children. Very often children are moved quickly, removed based on a judge's kind of abrupt decision. Often there's no transition for the child, no explanation. And this is a place where we can make a difference for children to advocate with their lawyers and foster agencies the need for developmentally appropriate transitions, gradual transitions between caregivers, a sense of camaraderie between caregivers, the child's ability to hold on to some people instead of losing them entirely with a move. We can offer to provide therapeutic supports through visits. Some new Medicaid regulations make some off-site billing more possible now than it was before. And we need to highlight for everybody involved the need to support children's relationships. Some of the therapeutic modalities that are a particularly good fit for young children in foster care are child-parent psychotherapy, which focuses on children's traumatic histories and on their attachments. And attachment and biobehavioral catch-up, ABC, which was also developed specifically for young children in foster care. In New York City, ABC is now being implemented through Power of Two, and it's widely available throughout the city at this time. Film or filming interactions to nurture development is a video coaching model that has high levels of efficacy for young children in foster care. It tends not to be too available in New York City, at least to my knowledge. For parents on their own, Parenting Journey is a parent group that helps parents reflect on their own childhoods and on the parenting they would like to offer as they reflect more on how they were parented. And Circles of Security is an attachment-based parenting group that helps parents understand children's need for attachment for secure attachment to caregiving adults. Okay, we'll talk a little bit about therapeutic resources. Most importantly and timely at this point, some of you may know that Sesame Street has just introduced a new Muppet who's in foster care. Her name is Carly, and she talks about her for now parents who are her foster parents. If you look on Sesame Street in the community, you'll find a lot of interactive storybooks, printable activities, and videos that involve Carly and her foster parents and the people in the neighborhood who consider what foster care means. Sesame Street also has a toolkit for children who have incarcerated parents. There are DVDs and coloring books and other things that help children understand what incarceration is and help their caregivers be able to speak to them in developmentally appropriate ways and in validating ways about where their parents are. There are lots of books that help us in our therapeutic work with young children. A Terrible Thing Happened describes a non-specific terrible thing and this little raccoon's response, bodily response and psychological response to the terrible thing that happened to him. There are the books by Chandra Ghosh Ibn, Once I Was Very, Very Scared, which also describes responses to animal characters to very, very frightening events. And her newest book, You Weren't With Me, which speaks to traumatic separations. Again, very typical for young children in foster care. These are really important therapeutic tools and are available through, I believe, the 0 to 3 website and also through Amazon. This is an old book now, but still a really good book, Visiting Day, for children with incarcerated parents that talk about a child visiting an uncle in jail and kind of give an explanation of what that's like. I mentioned picture books for children. Here are some examples of books that are available. I Am Here For You Now is a photo book where you can insert photos of the adults who are currently in the child's life, and it has a repeated refrain, I'm here for you now, as it acknowledges some of the frightening events that children have been through. This is a generic photo album for infants and toddlers that I believe is offered through Lakeshore, and you can put in pictures and captions that match children from parents and children from previous foster homes, birth parents, whoever you want to keep memories for the young child. And this is a toddler-friendly book with plastic screens and this cloth. I want to mention Rise Magazine, which is a wonderful resource for parents who have children removed and placed in foster care. Rise Magazine is a magazine that's written by and for parents of children who have been placed in foster care. They have regular editions, regularly printed regular editions, but they also have special topic editions. And they most recently have tip sheets for parents that give them lots of good guidance on how to deal with aspects of their case. This is a really valuable resource for parents. This is an example of a RISE tip sheet about visiting. It gives parents very concrete ideas for things that they should do or should not do in the context of children's visits. There are many RISE tip sheets related to a lot of aspects of participation in your case. These are all, if you just Google RISE, they're all very downloadable and free and available. RISE also has a handbook called Building a Bridge, which gives guidance on how to promote better relationships between parents and foster parents. Also a very good resource for this kind of work. For children whose parents are incarcerated and who may not be able to visit parents in jails or prisons, there are a lot of video visiting resources available, becoming specifically geared to very young children. So the Osborne Association has a video visiting capacity, and they surround those videos with psychotherapeutic support for both the incarcerated parent and for the young child. The Child Center of New York and Queens also does video visiting for children with incarcerated parents, as does the New York Public Library. And some of you may know that ACS has a CHIP program which takes children on child-sensitive and child-friendly visits to incarcerated parents. I'm sorry if that sounds like an oxymoron to have a child-friendly visit to a prison, but they do it with as much sensitivity as possible for a young child. And often those are more protected visits, protection from things like going through extreme security measures than when children and families go outside of the CHIP context. I want to mention that reunification with a parent is not the end of the story. For very young children, often that is a period of high risk. If parents and children have not lived together, the sudden reunification may be rocky. I mentioned earlier in the webinar the 20 to 25% rate of return to foster care after children have been reunited. That, I think, reflects the fact that our services didn't repair the problems the child welfare system set out to repair, but it also reflects the fact that this is a stress period for children and parents. So what can we do in terms of providing reunification supports? You may be surprised to learn that we can engage the services of preventive programs as children are coming out of the foster care system. It is possible for a foster agency to connect parents to a preventive program even prior to the child coming home so that there's no gap in services. Many of the home visiting programs that we're blessed to have in New York City are very helpful for families. Healthy Families Home Visiting Program, Early Head Start as another example, Parent-Child Home Programs are all generic community-based non-clinical programs that have a high level of efficacy in preventing child maltreatment. And of course, getting our kids into very high quality early childhood programs is a protective factor. I mentioned Power of Two, which is an intervention that was initially designed for foster parents, but after children are returned home to their parents, Power of Two will repeat the attachment-based intervention with children and their birth parents once the kids are home. Okay, so I'm glad that we have a few minutes at least in case there are any questions.
They're posted. Okay. With the Google Doc right there.
Okay. Okay, so the first question is, how can we engage foster children better in schools? They tend to drop out of school when they feel overwhelmed. This question, I guess, reflects a little bit more the experience of older children. Our young children are fortunate if they get into good programs, and again, I mentioned the need to support those placements in good preschool programs by making ourselves available to teachers. For older children, as I guess this question is alluding to, again, we need trauma-focused approaches in our schools so that teachers understand children's dysregulation, behavior problems, or learning difficulties as reflections of traumatic experiences and attachment disorders and disruptions. Certainly not all the time, but in the case of children in foster care, I would suspect that that is a reason for their school failure or their school dropout a lot of the time. I'm happy to say that from my limited knowledge of what goes on in school for older children, I have become aware of some efforts in the New York City public schools to introduce trauma-informed care. I was at a recent forum in the Bronx where this is taking place. So I'm hoping that more training for teachers on trauma-informed care and mental health co-location of services in schools will address the problems that you're alluding to.
So we have time for one other question if someone would like to type it in.
Can you speak to any experience in working with biological parents with developmental disabilities and how this impacts the likelihood of reunification as well as dyadic trauma-focused treatment? That's a great question because that is a common problem, and it's also an area where there is not that much resource. I can tell you that in the ACS concept paper for preventive programs, that is the paper that guided service providers to apply for specific preventive models that ACS would then fund. There was a request for proposals for a preventive program specifically for parents with developmental or intellectual disabilities, and I was very happy to see that. There have been some programs throughout the history of New York City that I've been familiar with of programs that have been developed for parents with intellectual and developmental disabilities, but they've often been short-lived as funding has expired. The one program that I do know about is at Synergia, but that is of limited assistance in that it consists of parent groups primarily, and parents have to get to the groups. I don't think there's child care, so it's of use for a certain select number of parents who can travel independently, but I think what we want more often for parents with intellectual disabilities is in-home services that help model appropriate parenting, and that is sorely lacking. Hoping that these new preventive programs will have some of that. B2H, when it existed, I know it doesn't anymore, did some of that. They did, if the child had a developmental disability and the parent did as well, they did a lot of in-home support, but I'm quite sure those programs don't exist anymore. So yes, acknowledging it's a very important problem. There are limited interventions right now. Hopefully with these new preventive programs, hopefully some organizations will respond and try to propose programs specifically for those types of parents.
So we're at the end of our time, and I just wanted to thank you, Susan, for an incredibly informative webinar here. And I want to thank you all for joining us. Please do stay tuned and go to our website to find out about upcoming events. We will be doing a webinar on psychopharmacology in young children by Dr. Rebecca Weiss and several other events coming up. We have Walter Gilliam coming to New York on October 28th. So please go to ttacny.org. And again, thank you, Dr. Chinitz, for an incredibly rich presentation.
Okay, thank you all for joining.